Caesarean section is a life-saving intervention, usually with purpose to save the life of both the mother and the baby. A caesarean section is basically when a woman has to deliver a baby through an incision put on the abdomen. On the abdomen, there are times when we put on an incision which goes as low down as a bikini, where, assuming someone is swimming, nobody can see such an incision. Or there are times when we use what we term as a midline subumbilical incision. Women too, they face that challenge where at times the delivery is not as what is anticipated by majority of them. A number of them would prefer to deliver naturally. Although, of course, with a changing environment, a number of things sometimes come up and say, doctor, maybe I should deliver by caesarean section. We prefer that that is done by a skilled person in an environment which is appropriate for that, regarding safety in terms of minimizing infection as much as possible, and of course having the appropriate equipment and the appropriate personnel to perform the procedure. The fetus may be big. Some women, it may be difficult to push such a child. It's a common indication. And then in some situations, the baby's heartbeat could have become abnormal. Abnormal in that if this child remained inside the mother's womb with that abnormal heart, if detected, by the time the mother goes through the process of labor, already we could have lost the child. And in medical terms, we tend to use the term of non-reassuring fetal heart, or at times some people commonly talk about fetal distress. But the whole issue that if this mother is allowed to continue in labor, there are chances that by the time she goes through the entire process, the fetus may be dead. And then there are also indications when the baby's cord, that tube, which helps to connect the baby to the placenta, which is like that area which acts as a source of nourishment and oxygen for the baby. If that tube, the umbilical cord, prolapses through before the baby is born, then at times, quite often we have to deliver that child by emergency caesarean section. And then other indications can be that there's a malpresentation of the baby inside, or even when a certain part of the head is not lying properly. Because usually the best position for the baby is when this head can flex nicely. In other words, there's a way it has to be positioned in a very good manner, but otherwise, at times, if this part of the head decides to the face facing upwards, or any of those other abnormal positions, such that the diameter, what we term as the diameter, presenting to the pelvis becomes so big, then it becomes very difficult. The indications related to the why we do caesarean section because of the mother, indication as a result of the mother, is when the maternal mother's bones are not wide enough to allow this baby to pass. And then at times the mother suffered complications, medical complications, which can put her in danger if she delivers. All complications, like at times she comes in and she has very high blood pressures, which if controlled and the mouth of the womb has not opened nicely, at times we decide that, oh, let's deliver this woman by caesarean section. Or there are times when the mother does what? The cervix, that is the mouth of the uterus, fails to open. Because that mouth of the uterus has to open up to a distance or a diameter of 10 centimeters. Or there are times when this woman has previously been exposed to, say, as previous caesarean section because of a recurring condition, like if the pelvis is small, or if the woman has been operated on at least twice and above. Usually, we decide to plan her for caesarean section. The immediate risks associated with caesarean section are things like excessive bleeding, because caesarean section, though it's a life-saving intervention, apparently it is associated with increased risk of death of the mother of almost about 4 to 5 times compared to the vaginal birth. So one of the risks of fear is that those complications which come as a result of excessive bleeding, sometimes the risks associated with anesthesia, because when a woman is being operated, it's not just a matter of cutting. She has to be prepared, taken through a process of being given the anesthesia medication to take off the pain, because there are various modalities of giving anesthesia. But the whole issue that taking off the pain so that the mother is able to undergo the process. But some women end up reacting to some of those anesthetic drugs. Some women end up developing severe infection in the wound itself. In the wound where the incision has been made, they end up having severe infection, in most cases as a result of what transpired before the woman coming over to theatre, because some people have had delayed labor, prolonged labor, they get obstructed, and then when they are delivered, then they end up having this complication where pus started oozing from the wound or even coming from the private parts. That can be very dangerous. We use the term puerperosepsis. It's among the puerperosepsis is one of the major killers of our mothers, like about number 3, when it follows the excessive bleeding and hypertensive complication and then puerperosepsis. So there are some women who suffer psychological problems because they've been subjected to a cesarean section. And others, because when you've had a cesarean section, in future deliveries, some end up delivering normally, but some are prone to other complications like risk of uterine rupture, especially if the pregnancy interval is short, or in case labor is prolonged. In case this woman is faced with a situation whereby she's going to deliver by cesarean section, what kind of information do we put forward? We explain to them the indication of the cesarean section. In most cases, we do it as a last resort because we've planned and thought that most likely this will be the best way for that lady to deliver. Like what I explained earlier, that there can be indications as a result of the baby you are carrying inside, in utero, or because of the indications related to the mother herself. We try to explain to her why is it that maybe this has to be done based on the indication of the cesarean section. And then we discuss with her what should happen before she goes to theatre, assuming that time is available, because some women come in as emergencies and there's very minimal time. That's why we tend to emphasize a lot even during antenatal care. As they receive their antenatal, women to appreciate that, well, an indication, anything can happen, that even though you are planning to have a normal delivery, certain things can change when you're in labor or during pregnancy itself, that an indication for cesarean section can come up. That one is relative, but on average, we tend to offer it 4 times, but mothers decide. Usually, many have done it even up to about 9. There's somewhere I read where someone had had it about 12 times. So it is relative, but on average, we tend to encourage women that maybe up to around 4 times, because every cesarean section is associated with its own risk. But in most cases, the family is allowed to decide. We offer the information and we inform them about some of the complications. If the indication of the previous cesarean section is not a recurrent cause, like as I explained earlier, that if, for example, the mother's bones pelvis is okay, if the presentation of the baby is a head presenting, if the baby size is normal and the lie is normal, we allow, and the heartbeat is normal, we usually allow such a mother to give a try to normal delivery. And during the process of monitoring, many women have successfully delivered, even following a previous cesarean section. In our setting, we tend to allow it for only if one has had one previous cesarean section, non-recurrent cause. Healing is relative, but on average, like for example, when a woman is operated, there are no major complications, she's breastfeeding the baby well, or the baby may even be in another place like NICU, where the newborns are looked after if they have complications. As soon as the mother is strong enough to be taken there, we encourage that she moves as fast as possible. If she's doing well without complications, on average, we discharge our mothers after the 3rd postoperative day. So we realize that women can be discharged to their residences within 72 hours to interact with family. It even enhances healing, as long as there are no major complications. But regarding the relationship sexually with a husband, when can a woman resume sex? The woman herself should be the determinant, preferably after the first 6 weeks. We usually say, hold on, be patient until that period is done. Some ladies at times communicate that, doctor, I don't feel strong enough until after like a period of 3 months. Remember where they've put a scar, these first 6 weeks, which we recommend, is time for healing. But even then, though healing has taken place, it's not yet strong enough. So we discourage women from conceiving again when that scar is less than a year. We would encourage that if a woman is to conceive, the best is to wait for at least 2 years from the time of the previous pregnancy to consider of thinking of getting pregnant again. And even that one, when the woman has spent at least a minimum of 2 years from the time of the last pregnancy before conceiving again, it gives a chance, a better chance to give you a trial of labor. Because if the conception is so soon, so fast, then it reduces on your chance of being given a trial of labor. When the interval is so short, especially if it is within the first 1 year, we usually say, this is a short inter-pregnancy interval, and the fear of the risk of rupture is high. So we tend to operate such women more often. Well, thank you for that question. If this is to go to the fellow health workers, one, I want to thank them for the work they are doing and the efforts they are doing to save the lives of both the mothers and their newborns. All I want to encourage them is that let them always endeavor to follow the available essential maternal newborn guidelines to guide them on what else we need to do. And then to ensure that by the time we do cesarean section, there is a clear indication for that cesarean section, because cesarean section is not 100% safe. It's also associated with the increased risk of severe morbidity and mortality of the mother. According to the research on the wider population, increased risk of about 4 to 5 times increased risk of death when you check on what is documented in the literature. So by the time we say let's deliver by cesarean section, the indication needs to be clear. And then the other thing is that once we've done, when we are planning for cesarean section, it's always very important to have the issues of the safety of the mother. When you are going to operate, remember the surgical safety checklist to ensure that we try to minimize some of the complications like living in a foreign body. And during the operation itself, always endeavor to be keen so that we don't leave a bleeder, because we've lost mothers after cesarean section. And if a woman has been operated on, I would stress more both to the midwife and the doctor, let's not abandon the mother, let's monitor closely, especially within the first 6 hours. Let's ensure that the first 2 hours, this woman is checked on at least every 15 to 30 minutes, check out the level, the pulse, the blood pressure, the breathing, check to see whether the uterus is well contracted, because excessive bleeding after cesarean section is another major killer of our mothers. Proper preparation during antenatal, proper preparation before theater, proper procedures during theater, proper monitoring, and the timely interventions after surgery are critical to ensure that we improve the outcomes as a result of cesarean section.